So today I'm going to be talking about the Victorian Perinatal Project, where we aim to map the delivery of interventions for vaccine preventable infections during pregnancy. So overall, we looked at hepatitis B, influenza, and pertussis. However, due to the interest of this group and also time, I'm going to be focusing on hepatitis B, but obviously very happy to answer any questions about influenza or pertussis. So essentially, we had three studies. The first was a community qualitative lived experience study, where we wanted to explore how mothers with hepatitis B understand and experience PMTCT, which is the prevention of mother-to-child transmission. The second study was a data linkage and analysis, where we wanted to estimate the uptake of hepatitis B mother-to-child transmission interventions, so especially looking at vaccinations. And the third study was the system mapping, inclusive of hepatitis B, influenza, and pertussis. And we wanted to look at service delivery barriers for the uptake of these interventions. I'd like to acknowledge the Department of Health, Victorian Department of Health, for funding this project and being a key partner, as well as Liverwell and Burnett Institute as key partners. And I also like to acknowledge participants and healthcare services who have tremendously contributed to this project. Again, please feel free to interrupt and ask questions, but I'll also save some time at the end for any questions. Next slide, please. So we know there are about 800 women in Victoria who give birth living with chronic hepatitis B. And that evidence of this evidence of local mother-child transmission, both in Victoria, but also in other states in Australia. As mentioned by the previous speakers, we know that children who are exposed to hepatitis B perinatally have a higher risk of developing chronic hepatitis B. Hepatitis B mother-to-child transmission is a key priority, both in the national hepatitis B strategy and also the state strategy, but it's also part of the WHO guidelines of triple elimination, which is hepatitis B, syphilis, and HIV. Next slide, please. Just to give you a bit of a quick methodology. So we were interested in women's experiences about service delivery, how they understood hepatitis B, the child's vaccination, what information was provided to them, and importantly, how they understood that information. I'll also like to acknowledge that this study was co-designed with mothers with hepatitis B, and we spoken to women, recruited women through purposive snowballing sampling, which means targeted approaches and word of mouth. Next slide, please. So overall, we interviewed 16 women, 11 were born in the Asian region, 5 born in Africa, 7 women required an interpreter. Overall, participants spoke about 10 languages. And 12 of these women had a primary or secondary education. So I'll be going through some of the key themes, findings that we explored in the study. So most women were diagnosed at an incredible time, either during pre or post migration to Australia or during antenatal screening, as explained here by the shock of Tham. There was also little to no hepatitis B information provided to women, particularly at maternity services. As Arif describes here, she wasn't told anything about hepatitis B. There was also intergenerational impact of hepatitis B, where women talked about hepatitis B within their close family, within their community, and also friends. Next slide, please. Understanding of hepatitis B varied across participants. So most didn't have a good understanding of hepatitis B, as explained here by Fatu, who explains that hepatitis B progresses in time, but she wasn't aware that treatment is available. And Yuri was also told that she is a carrier, but she didn't really understand what that meant for her. Few women also understood the link between hepatitis B and liver cancer, which we've all talked about this morning, the importance of that understanding within communities. Next slide, please. So understanding of vaccination itself also varied, and most women understood the basics of or the principles of the vaccination, but some women were confused about its protection and also uncertainty about the purpose of the vaccination. Two women were unaware that their children were vaccinated at birth and actually confused the routine heel prick that's conducted at birth to screen other medical conditions to be hepatitis B testing. So when I asked and probed about hepatitis B vaccination, in their mind, they were thinking, well, my child has already been tested for hepatitis B, so I don't really sort of understand these questions about vaccination, which I think really highlights a key point about consent and how that's conducted and how women understand these. Two women were also advised not to breast their infant, fear of transmission. So Amala here was advised by a healthcare provider not to breastfeed for 24 hours, which we know is obviously inaccurate, and it is safe to breastfeed while a woman has hepatitis B. Next slide, please. There was also low hepatitis B discussion and information provided to women. As Fatima explains here, she was tested at each pregnancy, but wasn't provided much information about hepatitis B. Low health literacy and low English proficiency was also another challenge for women. As Amal describes here, even with an interpreter, it was challenging for her. There was also low hepatitis B post-vaccination testing advice for women. We know that it's critical to test children who are born to women with hepatitis B to confirm that the vaccination has been successful and that mother-to-child transmission has been averted. However, most women were not advised to test. And the few that were advised to test their children post-vaccination actually faced some challenges. So as Rose explains here, she attempted to test her child a few times, but unfortunately was unable to because the pathology clinic didn't have enough nurses. So she was advised to either come back a few times or go to a hospital. Next slide, please. There was also mother-to-child transmission concerns, as Third explains here, that both her and husband have chronic hepatitis B and that she's worried of passing hepatitis B to her children. San also explains that she wanted her baby bathed before the vaccination, and this was again being worried that the chance of the bodily fluids being carried by the vaccination needle, and she was really worried and stressed that her child wasn't bathed before vaccination. Fatu also explained here in the last quote that she's worried about hepatitis B and its long impact in terms of liver disease, or chronic hepatitis B liver disease. Women were also worried about sharing personal items with their children and their family, even when their children were all vaccinated. So I think there's a great need of education and support for women with hepatitis B. Next slide, please. So in summary, diagnosis occurred at a really complex time for women. As you can imagine, being pregnant and having a baby itself is very stressful. And on top of that, to be diagnosed with a chronic disease. There was also little to no formal hepatitis B information, and therefore women had poor understanding of hepatitis B. There was also concerns of mother-to-child transmission and also liver cancer. And there was poor social and emotional support, and this was particularly during diagnosis and postnatally. And there were no relevant specific chronic hepatitis B and pregnancy resources for women. Next slide, please. I'll now move on to the data analysis, linkage analysis study. So basically, just to give you a bit of a background, we linked large data sets, and by we, I mean my colleagues, Nicole Rivero and Anna Deng within our team, but also acknowledging Stacey Rowe at the Department of Health, where we linked large data sets, so the Victorian perinatal data collection to identify pregnant women, the FES, which is the Public Health Events Surveillance System to collect hepatitis B notifications, the Victorian Admitted Episode dataset, which is basically birthing details via the hospital, and also the Australian Immunisation Registrar. Next slide, please. So overall, there were nearly 700,000 mother-infant pairs identified, and of that, just less than 1%, excuse me, had chronic hepatitis B diagnosis. Next slide, please. So this is looking at the uptake of hepatitis B birth dose during 2017. As you can see, the first graph is looking, or chart is looking at the general population, and the one on the right is looking at specifically infants born to mother with hepatitis B. So I'll also like to note that prior to 2017, timely birth dose was recorded as less than 7 days. However, in 2017, that has changed to less than 24 hours, which is the recommendation. So the dark blue is less than 24, light blue is between 24 hours and 7 days. Green is after 7 days, red is not recorded, and the gray is not stated. So as you can see, for the general population, timely birth dose, so within 24 hours, was just under 85%, which is below the, hepatitis B birth dose guidelines. For the infants born to mother with hepatitis B, that's just above 95%, and really that should be 100% to make sure that mother-child transmission doesn't occur. So overall, 1 in 20 infants born to women with hepatitis B did not receive timely birth dose during 2017, which is really staggering. Next slide, please. We also looked at timely birth dose uptake by hospital. And as you can see in this graph, what we've done is we grouped the top 20 hospitals by the uptake of timely hepatitis B birth dose. So the blue is the number of hospitals, gray is the number of births by hospital. And as you can see here, just focusing on the middle two bars, about 9 hospitals reached only 90 to 94% of timely birth dose uptake. And as you can see, the gray, that's the number of births. So those hospitals have the highest number of births in Victoria, and that should be really close to 100% as possible, or 95%. Next slide, please. This is looking specifically at infants born to women with hepatitis B. Again, as we mentioned earlier, the aim is 100% of timely birth dose for infants. However, as you can see, only 9 hospitals were able to deliver 100% of timely birth dose in 2017. Next slide, please. We also looked at factors associated with hepatitis B birth dose. This is within 7 days, looking at infants born to mothers with hepatitis B. And what I would like to focus on is sort of the blue highlighted section. So children were more likely to be give a timely birth dose if their mother was born overseas, or if she had a indigenous status recording. It's not in there, but they were more likely. However, infants were less likely to be vaccinated in a timely manner if they were born in private hospital or if they were underweight. Next, please. There were also issues of hepatitis B status recording, which obviously we know is critical to identify women and to make sure that women receive the best of care in terms of clinical care, but also making sure that their children are looked after. So basically here we've got is 3 day, you can see the inconsistency of recording of hepatitis B status. So essentially about 40% of hepatitis B status were not recorded in all 3 systems. Next slide, please. There was a poor recording of hepatitis B immunoglobulin throughout the study. And what we could only find was that only 129 doses of HBIG administration. However, this is due to poor recording of HBIG, we think, but again, it's really hard to comment on it because we don't have a standard method of recording HBIG. There was also evidence of local mother-to-child transmission. So through this study, we found 8 infants born in Victoria who had a chronic hepatitis B diagnosis recorded. Next slide, please. I will now move on to the last study, the system mapping study. Next, please. Sorry, that graph is a little bit too small, but essentially what we wanted to do was to understand how these interventions for influenza, pertussis, and chronic hepatitis B were delivered in Victoria. And we really wanted to understand what are the barriers for service providers in terms of providing women with optimal care. So after initial consultations with key healthcare providers, this was back 2019 before COVID, which was really exciting, we developed 2 online surveys. So the first survey was for maternity unit managers in birthing hospitals, and we really wanted to find out on the ground what are the challenges for women, what are the challenges for healthcare providers, and what could be some of the ways that we can improve things. The second survey was for healthcare providers who are involved in the care of women. So this could be both in the hospital or in the community. Next slide, please. So I'll firstly go through the birthing hospital survey results. Survey was sent to all birthing hospitals within Victoria. At the time, that was about 56 hospitals, and we had 34 hospitals who responded to the survey. As you can see, most were public hospitals across Victoria, and 85% of the people who completed the survey were maternity unit managers, which is exactly who we were targeting. So next slide, please. Just overall of the 34 hospitals who completed the survey, 53% said they had a ID physician specialist within their service. Next slide. So we asked if there was a standard procedure to confirm a woman's hepatitis B status, and what we found that some people, checked their medical record or conducted a hepatitis B test. However, it was surprising to find that about 11 services relied on verbal report from the women. And as you can imagine, that's incredibly hard to remember what diagnosis you have, but also for women who might not speak English or might have low health literacy. Next slide, please. We also asked if there was a standardized protocol for seeking consent for hepatitis B and HB administration before delivery. And so the blue is yes and the orange is no. As you can see, there were a number of hospitals who didn't have a standardized protocol for seeking consent, which really correlates the experiences of women we've heard previously. Next slide, please. Some of the key barriers for hepatitis B birth dose and HB administration within services were vaccine stock out, and this was particularly HB. There were 3 hospitals who didn't have a supply of HB. There was one who didn't routinely have one in stock. And as you can imagine, this would be incredibly difficult if they had a woman give birth within their hospital. And I think that just highlights the access issue for women with hepatitis B, particularly for private hospitals, but also regional hospitals as well. And there was also other challenges around staff awareness and attitudes towards hepatitis B vaccinations and care. Next slide, please. This slide is looking at barriers to guideline-based care. So the previous one was only looking at vaccination. This is looking at the overall barriers to care. And as you can see, the highest one is the key barriers for services were there was no infectious diseases specialist at their service, and staff training and awareness, lack of communication between services was also another one. And again, unclear recording of women's hepatitis B status and no standardized procedures and protocols. And this one really is looking at healthcare providers said, we have enough guidelines, we don't need any more, but what we need is a standardized implementation protocol. So it doesn't matter which hospital you give birth, the standard is the same, the implementation of care, clinical care for women, and administration for vaccination for the infants was also the same, regardless of where you gave birth. Next slide, please. I will now move on to the healthcare provider survey. So overall, 140 participants responded to the healthcare provider survey. 57 were in hospital, mainly public hospitals, and 83 were from community. And as you can see, there's a breakdown of where those services were located. Next slide, please. So we asked similar questions about how do you confirm a woman's hepatitis B status, and as you can see, there's a different breakdowns of people checking medical records or ordering a hepatitis B test. But again, looking at the yellow arrow, there's still a large number of services that are relying on verbal report from the women. And 3 services who don't apparently confirm a woman's hepatitis B status, which is more concerning. The right graph is looking at, okay, so women tests positive, what are the next steps within your service to look after women? And as you can see, most women were either referred externally or looked after within the service. However, 4 hospitals said, services, they don't test women at all, and 2 said there is no further action taken. Next slide, please. We asked the same question about the consent for hepatitis B and HB administration. And as you can see, some services didn't have a standardized protocol for seeking consent from others. Next slide, please. Okay, so this is a really busy graph, but I'd like to think that it tells a story. So we asked healthcare providers on a scale of 1 to 5, how confident are they that all pregnant women are offered hepatitis B testing, if they have hepatitis B, if they're on treatment, and if they are linked to care. Obviously, 1 being not very confident at all, and 5 being very, very confident. As you can see in the first graph, most felt confident that all pregnant women are tested for hepatitis B. But as you can see, that confidence kind of wavers and decreases as you go through the cascade of care. So the second graph is, all pregnant women receive DNA testing, viral load testing, and the bottom left graph is looking at, okay, so if a woman has a high viral load, how confident are you that she's prescribed treatment? And as you can see, there isn't, that should really be very confident across the board, but as you can see, there's some gaps. And the last one is looking at confidence regarding women are linked to ongoing care, which we know is very important even after birth. Next slide, please. Some of the key barriers identified within the healthcare provider survey were again similar to the birthing survey. One being, there's no standardized procedures for implementation for hepatitis B care. Staff awareness and training. There's no standard order, vaccine supply issues, women declining vaccination, which was I think lower than we expected, but there was also concerns about lack of clarity on who's responsible for the administration of birth dose and HB, which surprised us because you would think, if a woman gives birth in a hospital, it doesn't matter if it's the midwife or the nurse or doctor, but that she gets that vaccination for her infant. Again, this is looking at, next slide. Barriers to guideline-based care for women with hepatitis B. And as you can see, the key challenges is that some people said all of the above, but as you can see, it's quite similar to what we've heard from the birthing hospitals in terms of, lack of communication or no ID physician, and that there were no standardized procedures or policies. Next slide, please. So this is my last slide, and this is looking at opportunities to improve care for women with hepatitis B. So really what we need is to coordinate a system coordination strengthening across the board, including a statewide coordinated care delivery implementation protocol. It's one thing to have guidelines, but it's another to implement those guidelines. And I think if healthcare providers and services are not supported, it becomes really difficult to implement those. Also, I think there's a great opportunity for the follow-up of children who are diagnosed with hepatitis B, particularly those who are under 10 years of age. Currently, we don't have an estimate of the rate of mother-to-child transmission because that post-vaccination testing isn't occurring, or there's no recording of it, so we don't really have a sense of what that looks like. We also need to explore the barriers for HPIC stockade and perhaps find out what are the challenges for those hospitals who run out of vaccination, and how can we support them better to improve care for mothers with hepatitis B and their children. And also a greater communication between services. One of the healthcare providers that we interviewed said, as a GP, you see a woman, you refer her to a tertiary hospital. It's almost like she goes to a tunnel train, and then, it's all dark and pitch and you have no contact with her. It sounds like a scary movie. But then she comes out at the end of the train track and you find her with a baby, and you're just like, what happened? Well, there's sort of no communication between that pregnancy phase. I think there's also a greater need for workforce development and training to, upskill our healthcare providers and support them to look after women. And also greater education and support for mothers with hepatitis B, and not just sort of during pregnancy, but making sure women are supported, psychologically, perhaps through a peer education or bicultural workers support, whether that's within hospital or within services. I think supporting women psychologically and emotionally is one thing that perhaps I think we really need to tap into. And it's not just about, I guess, the clinical care or the steps that we can count, but a lot of it is that, what happens when the mother goes home.